Right, getting into our different GI disorders that we're going to talk about. First, you need to have a basic understanding of the anatomy and physiology of the GI system. So, digestion occurs the same in children and infants just as it does in the adult. At the junction of the esophagus and the stomach is the gastroesophageal sphincter. In newborns, that sphincter is immature. It allows fluid to easily regurgitate into the esophagus. So, we'll talk about that disorder later, and that's GER or gastroesophageal reflux. At the distal end of the stomach is the pyloric sphincter. In some infants, this muscular channel actually becomes stenosed and it prevents food from flowing out of the stomach freely into the intestines, and that's actually called pyloric stenosis. We'll talk about that disorder later as well. An organism that can and does survive in the stomach, the Helicobacter pylori or H. pylori, that can actually lead to causes of peptic ulcer disease. And in the small intestine includes the duodenum, the jejunum, and the ileum. And the large intestine includes the cecum, the ascending colon, transverse colon, descending colon, the sigmoid colon, and the rectum. The appendix is actually attached to the cecum. Often that can become diseased in children. That'll be one of the disorders we talk about in this chapter. Some different diagnostic and therapeutic techniques that we use for GI disorders. We can do endoscopy, colonoscopy, radiologic studies like x-rays, ultrasounds, CT scans. Children do need to have a good preparation for any procedure that they're going to have because it is kind of frightening to them or potentially is frightening. So make sure you're giving clear and simple instructions at a developmental level they can understand about what's going to happen. Be reassured that a parent can remain with them until they fall asleep if we're using sedation. And involvement of child life specialists can also be helpful for a really anxious child. They have a great way of being able to developmentally prepare them as well as help them through any anxiety or give them distraction during a test or a procedure. Different therapies can include alternative methods of feeding like NG or G-tube feedings, TPN, IV therapy, and those are all meant to oftentimes rest the GI tract. A colostomy or an ileostomy can also be created to further rest the GI tract in some disorders. There's one we're going to talk about, like Hirschsprung's disease, that we do that. When it comes to health promotion and risk management for the GI system, health promotion is really related to GI disorders and it focuses on a wide area because the causes of these disorders can cover a wide range. So vitamin and protein deficiency disorders can be prevented by educating parents about the importance of a consistent, healthy diet. The vaccine to prevent rotavirus infections is recommended. You all know that from the immunizations you studied. We give them rotavirus vaccine. Families often need help with planning nutritional care. Sometimes they may need help in planning the necessary adaptations to their lifestyle to prevent the disease from interfering with family functioning. All families should be encouraged to eat at least one meal a day together so they can have time to share experiences and kind of touch base with each other. So having a sit-down meal at the dinner table or wherever they would gather for that meal is really important. It's also important to educate parents about normal nutrition and how to distinguish things such as vomiting from an illness that's from normal just spitting up, or severe diarrhea that's from a simple GI upset. An early intervention prevents the child from becoming dehydrated and seriously ill. Fluid electrolytes and acid-base imbalance. These can be a major source of fluid and electrolyte loss, and that would be vomiting or diarrhea. Retaining fluid is of greater importance in the body chemistry of infants compared to the adult, and that's because fluid constitutes a greater portion of body weight in infants and small children, so they can become a lot more easily dehydrated compared to the adult. Fluid is normally obtained through oral ingestion of fluid by water formed in a metabolic breakdown of food. Fluid is lost primarily from urine and feces, but there's also insensible losses that occur from evaporation from the skin, lungs, and saliva. Again, kids have a greater surface area to body mass that causes greater insensible losses of fluid. Infants have a greater loss of urine than adults, and that's because of their inability to concentrate urine because they have immature kidneys. And when diarrhea occurs or the child becomes diaphoretic due to a fever, again, fluid loss can be greater, leading to dehydration. This is just a nice reminder of how to do daily fluid maintenance requirements or how to calculate those. So if you're not familiar by now, you can review that here. These are a lot of the different common GI symptoms of illness that we see in infants and children. A lot of these should make a lot of sense to you. They're not really anything new. One that I would like to point out that you don't necessarily think about at the adult is lack of tearing. Oftentimes with infants and young children, when they cry, they tend to have tears. And if they are upset or looks like they're crying, but you don't see any tears, that could be a sign of a GI symptom or getting into dehydration. All right, our first topic we're going to talk about with GI disorders is vomiting. And vomiting isn't necessarily a specific disorder for GI, but it's one of the common symptoms or things that we will see with various GI disorders. So vomiting, we all know what that is. They can suffer from vomiting from mild gastroenteritis, which is an infection that can be caused by viral or bacterial organism. Assessment-wise, it'd be really important to differentiate between regurgitation and vomiting. And we're going to go through that chart that's listed on page 2 and 3 of your notes. There's different conditions that are marked by different forms of vomiting, and correct description of the child's actions can help us aid in diagnosis of particular disorders or rule things out. So really important if a family member or a parent caregiver comes in and says, my baby keeps vomiting or throwing up, well, you really need to ask some very specific questions, because oftentimes it's not really vomiting. It could just be simply regurgitation. So we're going to go through, like I said, that chart about comparing regurgitation to vomiting. That'd be a good thing to know. So I would definitely study that one. So I'm going to go through regurgitation first and then through the vomiting side of that chart. So with regurgitation, the timing, it often occurs with feedings or right around feedings, shortly after feedings typically. So its timing is around the feeding or recent feeding. Forcefulness. With regurgitation, it just runs out of the mouth with little force for your blank. The description of regurgitation, it smells barely sour and it's only slightly curdled. So barely sour and only slightly curdled. That's because it hasn't had that much time to be in contact with the stomach acids and contents to really have that time to get that really sour smell or that curdled look to it. So because it hasn't been in contact with those stomach fluids and acids, again, you're not going to have much of a smell. So it's going to be barely sour and slightly curdled. Distress. It's non-painful to the infant. They have no appearance of distress. They may even smile afterwards, almost like they feel better, that it's enjoyable, like they have some relief from that. And the duration with regurgitation, it typically only occurs once per feeding. And the amount with regurgitation is 1 to 2 teaspoons. Now with vomiting, you're going to see some definite differences. With vomiting, the timing is unrelated to a feeding. And with vomiting, the forcefulness, we can have forceful vomiting or we could even have projectile vomiting. So forceful vomiting is often projected about 1 foot away from the infant, where projectile vomiting can be projected as much as 4 feet away. Projectile vomiting is most often associated with pyloric stenosis, and we're going to talk about that disorder later on in this chapter. Description for vomiting, it's extremely sour smelling and it's curdled. It can be yellow, green, clear, or water, or it could be black or blood tinged. So again, extremely sour smelling and it has a curdled appearance. Why is that? Again, remember that's happening This vomiting is happening unrelated to a feeding. So it's had time to sit in the stomach. It's had time to start digesting and come in contact with those stomach acids. So again, leading to that extremely sour smell and the curdled appearance. Distress. Oftentimes there might be some crying just beforehand, right before the child or infant actually vomits. And it may be because there's some abdominal pain that's present. And then after vomiting, because it's so forceful of an action, it could be frightening to the child, which could, again, kind of create crying or some distress for the child. Vomiting, when it comes to duration, the child will continue to vomit until the stomach is empty. It could even be followed by dry retching, so that's no fun. And then the amount, with vomiting, it's going to be full stomach contents. Full stomach contents. So again, good idea to know the difference between regurgitation and vomiting and making sure we're asking the right kind of questions about timing, forcefulness, the description, distress, is there any distress, duration, and the amount. That can really help us distinguish what may be going on. When it comes to therapeutic management for vomiting, the treatment is really just related to gastroenteritis. Oftentimes what we'll recommend is just give some small amounts of fluid frequently, as tolerated by the infant or child, to really prevent dehydration and electrolyte imbalances. So oftentimes what we'll use is what's called oral rehydration solutions. So an example of that would be like Pedialyte, can be used for infants and young children as well as even older children for or with dehydration. We'll talk more about those in a little bit. Children who have intractable vomiting or severe dehydration, oral rehydration isn't going to be enough, even if they're willing to take it, or if they can't stop vomiting, oral hydration is not going to work. They would actually need IV fluids and need to be admitted or at least observed for a short amount of time until we can get things under control and get their hydration status back on track. Recommend looking at the nursing diagnosis and related interventions for further information. Right, next, we're going to talk about diarrhea. Again, diarrhea is not necessarily a specific GI disorder. It's a symptom that we can see with various disorders, but with diarrhea, you can also have mild diarrhea versus severe diarrhea, and we'll go through both of those. But diarrhea could also be acute or chronic. With acute, it's usually associated with infection of some sort. So it could be viral, it could be bacterial. Those viral and bacterial infections are easily spread in diaper changing areas and daycare centers or public restrooms, where chronic diarrhea is more likely to be related to malabsorption or an inflammatory cause. So an example of acute versus chronic, and acute diarrhea, that could be, again, like gastroenteritis. Or with chronic, since it's related more to malabsorption and inflammatory disorders, think about what we've talked about before with like cystic fibrosis. There's a malabsorption issue. Celiac disease, since we're in GI, that would certainly be an issue with malabsorption. So those are just a couple examples. In infants, it's always serious because infants, again, have smaller extracellular fluid reserve, so that sudden loss of water quickly exhausts the supply. Breastfeeding may actually actively prevent diarrhea, and the reason being is because what are they getting from mama that might help protect them? Well, they're getting more antibodies through that breast milk, so that can actually be a good thing for them, and we would want them to continue breastfeeding through a diarrheal type illness because, again, those antibodies that they're getting from mom can be super helpful. So getting into mild diarrhea and how we can distinguish it between mild and severe. So assessment wise, kind of have some anorexia, they're irritable, you can tell they just don't feel well, but their fever and the amount of stools and what they look like can help set it apart. So with mild diarrhea, their fever is usually 101 to 102 degrees Fahrenheit. And they tend to have anywhere from 2 to 10 loose, watery bowel movements per day. So fever of 101 to 102 degrees Fahrenheit, and they can have 2 to 10 loose, watery stools per day. Might be a good idea just to kind of look at differentiation between normal stool and diarrheal stool. Would also be important to understand And that differentiation too, especially with an infant, are they breastfed or are they formula fed? Because those stools look very different, and what those characteristics look very different. And again, that would be important to ask about and know what is the difference between what's expected and not expected. Our therapeutic management for mild diarrhea. For the most part, this can be cared for at home unless, of course, their condition would continue to worsen. We can teach parents how to help them manage this at home. The biggest thing is just rest the GI tract for a short time, roughly an hour. Rest the GI tract. And then begin oral rehydration solutions. So Pedialyte in small amounts or something similar to the regimen of vomiting. Again, for breastfed infants, they should continue breastfeeding. That's going to be more beneficial. And breast milk is considered actually clears. Something else that can also be administered when a child has diarrhea, something that can kind of help get that GI system back on track, probiotics. So for your blank, probiotics may be administered. We'd also want to make sure we take measures to reduce that elevated temperature. So acetaminophen, ibuprofen are good ways. Certainly just kind of sponging them down if their temperature is a little bit higher. We can't give them more medication. That's another way to do that. Make sure you're not dressing them in too many layers either. One thing we do want to caution parents about is make sure they contact their provider before initiating any sort of over-the-counter drugs like that are for diarrhea. So like loperamide, which would be Imodium, or kaopectate, because those levels can become toxic very quickly in an infant or young child. So unless the physician has directed them to do so, that is not something they should do on their own. Want to make sure parents are also reminded that they should be washing their hands after diaper changes. That's just to help prevent that spread of infection. So good hand washing. And then, of course, notify the healthcare provider if fever or pain or diarrhea actually worsens. So if the child is not improving and they continue to deteriorate, then we might need to look at doing something else for their management of the diarrhea. For severe diarrhea, our assessment, the infant's going to look obviously more ill, that they're not feeling well. Their temperature is going to be higher compared to mild. So the temperature can be as high as 103 to 104 degrees Fahrenheit. Because they are getting more dehydrated and they're just kind of sicker in general, their pulse and respirations are also going to be weak and rapid, which, think about it, you're also losing fluid that way if those respirations are rapid. Their skin is going to be pale and cool. They might be apprehensive, listless, and lethargic. And some obvious signs of dehydration that we can see in infants. What do you think their fontanelles are going to be like? Well, if they're dehydrated, they're going to be more sunken or depressed, either whichever way you want to put it, but sunken or depressed fontanelles. They might have sunken eyes, poor skin turgor, and then what do you think their stools are going to look like? They're going to be more liquid green stools, possibly even mixed with mucus and blood, especially if they were passed with a really explosive force. Their urine output is going to be scanty and concentrated. Not going to be much there because guess what? They've just lost their fluid in other ways. Again, those insensible losses, and especially with the diarrhea. When you think about labs and what kind of things might be different there, what do you think their hematocrit, hemoglobin, and their serum protein levels might be like? Well, they're going to be elevated. Why might those be elevated? Again, it has to do with our level of dehydration. So elevated hematocrit, hemoglobin, and serum protein levels because of the dehydration. And if you think about it, if our body is lacking fluids, guess what? Things are going to be a little more concentrated or viscous because of that dehydration. We would also need to determine what their electrolytes look like. It can indicate metabolic acidosis. And oftentimes, parents may report that they've had some weight loss because of the amount of diarrhea as well. Therapeutic management for severe diarrhea. We really want to focus on regulating the electrolyte and fluid balance. So if we can get them to take it orally, by all means, we're going to do it. But if they're feeling pretty crummy, they may not be able to do that. And if they can't, then we're going to look at doing IV rehydration therapy. So oral or IV rehydration therapy. We would also want to send off a stool culture. If diarrhea persists longer than 24 hours, then we should get a stool culture sent because we want to rule out, again, is it viral or bacterial? So if bacteria is present, then they're going to need a specific antibiotic ordered to treat that. We would also, again, look at blood serum levels. So looking at hemoglobin, white blood cell count, and differential, and their electrolyte levels to really establish, again, if there's an infectious process going on, and establish their hydration level or dehydration level. Again, if the child's able to drink, we're going to try and push the oral rehydration therapy. If they're not able to drink or cannot drink enough, then we're going to do an IV solution, typically of normal saline or 5% glucose in normal saline. We cannot add potassium to their fluids until we've ensured something's happened. So we need to make sure the child is not in renal failure. And we're going to know that they're not in renal failure, that things are functioning like they should with the kidneys, as long as they void. So if they void, then we know that their renal system is functioning well, and we can go ahead and add potassium then to the IV fluids that we are giving. Great. Now we're going to talk about the concept of oral rehydration that I've mentioned before, both with vomiting and diarrhea. So oral rehydration therapy, or often referred to as ORT, is one of the major worldwide health advances in the last decade. And typically we're talking about like Pedialyte, Gatorade, but you really need to be careful about Gatorade. It's probably not the best. Same thing with Powerade. It's not the best solution. Pedialyte's probably the better solution. It's safer, it's less painful, it's less costly than IV rehydration. So again, we really try and push the oral rehydration, or doing an oral challenge to see if they can take in enough fluid. So oral rehydration solution, it helps enhance and promote reabsorption of two things. It helps with reabsorption of water and sodium. So kind of always think about water and sodium. They always seem to go together, right? That can help reduce the vomiting, diarrhea, and just the duration of the illness itself. When it comes to nursing care, that's really about a lot of teaching with the family, just teaching about why we use oral rehydration therapy, what it is, and what maybe they would need to do. Because again, this could be even managed in the milder cases at home. If they're in the hospital and we're doing oral rehydration or watching them because of their dehydration status, we would want to get accurate daily weights using the same scale at the same time of day, making sure, with an infant, it would be a dry diaper only. For an older kid, then they need to be in a gown, usually after they've tried to void, if they're first getting up for the day. We want accurate eyes and nose. I'd really say more like strict eyes and nose, not just accurate. We'd want to monitor an IV site. If, again, they're in this more severe status, then we need an IV placement, so monitoring that. If we would need to collect stool specimens, we would collect those and send those off. We want to make sure we're protecting the skin from breakdown, because with vomiting or diarrhea, again, think of all the acid that can be in those, and that would break that skin down further and irritate it. So taking measures to use like skin barrier creams and making sure we clean them well between diaper changes can be helpful. Teach parents to use the commercially prepared oral rehydration solutions when the child experiences diarrhea, administer any medications as prescribed, and of course how to avoid the spread of infectious diseases in the first place. So prevention of diarrhea, the most common way that diarrhea is spread is by the fecal oral route. So again, teaching good personal hygiene, make sure that, especially for girls, wiping front to back, good hand washing, and just taking precautions when we're changing diapers and things like that. Clean water supply and protecting from contamination, not really a problem in our culture, in our country, but you got to think about in other places in the world, they don't always have supply to clean water. And then, of course, thinking about careful food preparation, just so there's not cross contamination. And for your two blanks underneath there, the first one is hand washing. I've already mentioned that before. Hand washing is really important. And then the vaccination that we would want to give is rotavirus to help prevent diarrhea. Great, now we're going to start really talking about various disorders in the GI system. We're going to start with common disorders of the stomach and duodenum. Our first disorder we're going to talk about is gastroesophageal reflux, or often referred to as GER. So GER is just regurgitation of stomach secretions into the esophagus through the lower esophageal sphincter. This is a normal physiologic process that occurs throughout the day in infants, children, and even adults. So GER in infants occurs because there's an immaturity of that lower esophageal sphincter, which allows for easy regurgitation of gastric contents into the esophagus. Very common, about 70% of infants are actually affected by this, and it usually will start within 1 week after birth. Even though the book calls it emesis, they're really getting at the emesis or vomiting. Again, this is why it would be important to know the difference between regurgitation versus vomiting. The emesis occurs after a feeding. It's effortless, and it consists of 1 to 2 ounces of undigested milk. So really, if you go back to the vomiting that we were talking about, it really falls more under that regurgitation characteristics than it does the actual vomiting characteristics. So GERD or GERD can also be diagnosed when infants develop complications from reflux. So GERD is a complication of gastroesophageal reflux. Symptoms of that can be irritability, failure to thrive, esophagitis, aspiration pneumonia, wheezing, and even apnea. Children with CP, which would be cerebral palsy or other neurological involvement, are at particular risk. Assessment-wise with gastroesophageal reflux, diagnosis can be made by the patient's history, just asking some detailed questions. We don't necessarily need to do diagnostic testing if it's an uncomplicated reflux. Patients with GERD, when we're getting into complications or having the disease from the reflux, they're more likely to get the diagnostic workup. And if they would do typically like an upper GI series, looking for any sort of anatomical abnormalities that are leading to that reflux and disease. They can do a pH probe to help calculate the amount of acid reflux into the esophagus in a 24-hour period. They can do esophageal mammometry to assess esophageal motility to make sure there's normal esophageal peristalsis. And they can even do endoscopy, obtain biopsies during that if need be, and that can help assess the degree of esophagitis that may be present. Therapeutic management for gastroesophageal reflux. It'd be important to explain that this is typically a very self-limiting condition. It just takes time for that esophageal sphincter to mature in infants and children. Once the child actually begins to eat solid foods, or the infant begins to eat solid foods, and they maintain a more upright position because they're able to sit propped up, we tend to see this problem disappear or certainly decrease drastically. Right? So getting into therapeutic management, one of the first things we're always going to do, we always try least invasive first. So we start with conservative management. And one of the first things we're going to do for your blank is positioning. So positioning, upright position for about 30 minutes after a feeding, if possible. Again, let gravity do its job. Makes it harder. If you laid them right down after a feeding when they're full, they're more likely to have reflux issues. The next conservative management we can do is dietary. Just simply thickening their feedings with about a tablespoon of rice cereal per ounce of formula or breast milk can be recommended. And what that does is it actually makes it heavier. Again, letting gravity kind of do its job, making it harder for it to reflux because it's a heavier substance. And then the last thing we can also do for conservative management is feeding modifications. Doing smaller, more frequent feedings versus these larger volumes, because larger volumes are going to put more distension and pressure on the abdomen, more likely to create the reflux. If we do smaller, more frequent feedings, hopefully we can decrease some of the incidence of the reflux that's occurring. You definitely would want to teach parents to avoid placing the infant in a car seat at home. Again, that actually puts pressure on the stomach and can lead to the emesis. We would also want to make sure they're not putting them in tight clothing or having really tight diapers on. Again, that just creates more pressure on that stomach, more likely to have the regurgitation or the reflux issue. Cigarette smoke. We've talked about how cigarette smoke is bad for kids in general. Here's another issue: cigarette smoke. Exposure to that can actually worsen reflux as well. So keep them away from cigarette smoke. And if we have a breastfeeding mom or an exclusively breastfeeding mom, have mom try to eliminate dairy from her diet or try a hypoallergenic formula for 2 weeks. Sometimes if it's a breastfed, either partially breastfed and formula fed, or an exclusively breastfed infant, something in mom's diet can actually be causing the reflux. So one of the first things we always ask moms to do, if that's an issue, is actually to eliminate dairy out of their diet, because that tends to be the biggest offending food. Or if they're a formula-fed baby, then we can try like a hypoallergenic formula, either something like Similac sensitive, Alimentum, something that would be easier for the infant to digest and hopefully reduce the reflux. But whenever you switch a formula, you have to give it a full 2 weeks. It can take a while to completely get out of the system and get accustomed to whatever the new formula is. When we get into pharmacologic therapy, there's no indication to do pharmacologic management for the uncomplicated reflux, but sometimes they will prescribe, or especially if we're getting into complications of the reflux, they may prescribe a pharmacologic management. So if they're experiencing irritability or poor feeding due to the esophagitis, we're seeing failure to thrive, something like that, then they can be prescribed a daily medication to help decrease the possibility of stomach acid irritating the esophagus, or those contents going into the esophagus and irritating it. So common ones are H2 receptor blockers like ranitidine, or Zantac would be the brand name, or we could do a proton pump inhibitor like omeprazole, or brand name is Prilosec. In some cases, we can do a surgical management as well, and I'll talk further about that in another slide. These are just some visual images of the various therapeutic management. So there's positioning, like using a wedge pillow, or just a way to be able to kind of prop them up so they're a little more upright after a feeding. Again, the rice cereal, where we can add that to make it thicker, adding weight to that breast milk or formula. And then again, in the cases where they might choose to do pharmacologic, Zantac is one of those options. So our surgical management that we can use for gastroesophageal reflux is not something that we would do lightly. This is kind of like we've tried everything else, it's not working, and we're still having disease issues or complications from the reflux, then we might look at doing a surgical management. And what they will do, the procedure they do is actually called a Nissen fundoplication. And it's where they will take the fundus of the stomach and wrap it around the distal portion of the esophagus. And what that does is it actually tightens it, making it harder or decrease the chance of reflux occurring. Again, they don't do this surgery lightly, because this is not something that's typically undone once it's has been completed. I've never seen actually having this reversed on anyone, and the few kids that I've had who've had this surgery performed aren't really able to vomit later on. So they might feel the need, or they might try, but nothing actually comes up. Oftentimes what I see kids do is really more like dry retching. So again, this isn't something that we go to lightly. It's more of if we're having really severe reflux issues and we're getting into those complications like esophagitis and failure to thrive issues, and we've tried the other conservative management or pharmacological management and it's not working, then we may go to this method. Gastrointestinal reflux in children and adolescents, we actually tend to call that GERD. And the only difference is that D part, right, that we add on. So GER versus GERD. That D really means, or GERD really means, compared to the gastroesophageal reflux, is that we have disease or damage that results from the gastroesophageal reflux. So disease or damage that results from gastroesophageal reflux. Chronic reflux potentially is dangerous because it can lead to erosion of the esophagus with perforation or strictures. It can be associated with the development of esophageal cancer later in life. And we tend to see GERD affect about 20% of adults, um, thought to be much lower in children, but again, maybe with diet, obesity, things like that, we're seeing GERD a little more frequently than we'd like. And sometimes, again, because of other medical problems contributing to that. So, clinical manifestations look very similar to the adult. They can have heartburn for 30 to 60 minutes after a meal. They might experience regurgitation as well. Diagnosis based on history. If symptoms are severe, then an endoscopy can reveal esophagitis. And our treatment, our goal is really to provide symptomatic relief and heal the esophagitis if that's identified. So, really, it's aimed at lifestyle changes. So, that therapeutic management, things we can do to prevent reflux from happening. Avoid lying down until 3 hours after a meal, staying upright. Sleep with the upper body elevated on a foam wedge or an extra pillow. Avoid acidic foods like tomato products, citrus fruits, or spicy foods. That will just enhance the reflux that they're having or heartburn. Avoid foods that delay gastric emptying, such as fatty foods, chocolate, or alcohol. Eating smaller proportions can be helpful. Losing weight if they're overweight. Avoid bending after meals. Puts pressure on the stomach, more likely to cause the reflux. Remove tight belts. Again, that puts pressure on the abdomen. Some over-the-counter medications that can be used. An antacid that can help relieve pain immediately. Histamine 2 blocker or proton pump inhibitors, just as with the infant. Our next disorder we're going to talk about is pyloric stenosis, or also called hypertrophic pyloric stenosis. It's constriction of the pyloric sphincter with an obstruction of the gastric outlet. So the lower portion of the stomach that connects to the small intestine is known as the pylorus. And in pyloric stenosis, the muscle in this part of the stomach actually enlarges and it narrows that opening of the pylorus, and eventually it can prevent food from moving from the stomach into the intestines. The incidence is pretty high. It is more common in the firstborn white male infant, but it can be seen in females as well. The cause is unknown, but they do believe there's a multifactorial inheritance that is likely. Assessment-wise, it usually begins around ages 4 to 6 weeks of age, and the infant will typically begin to vomit almost immediately after feeding. They actually will have projectile vomiting. So 3 to 4 feet from where the child is side lying, or if they're laying on their back, it could be up to 1 foot shortly after that feeding. So usually, again, 30 to 60 minutes after. So again, this is why it'd be so important to ask those questions about regurgitation versus vomiting characteristics, because again, this can help us get us to this diagnosis of pyloric stenosis. When they vomit, it's usually sour because it has reached the stomach and it's come in contact with those digestive enzymes. When the child does vomit, they immediately often will act hungry, either immediately after or very shortly after, and they kind of just have this constant hunger about them. They're not in any pain. It doesn't hurt. They can get into signs of, if they're constantly vomiting and nothing's moving out of the stomach, what do you think they're going to start to show signs and symptoms of? They're going to show signs of dehydration. So signs of dehydration. They can very quickly get into metabolic alkalosis, and that's because of that excessive loss of chloride from the loss of stomach fluids, which then can accompany hypochloremia, hypokalemia, and even starvation. They can have hypopenia, which is where the body tries to attempt to compensate for that alkalosis. When it comes to diagnostics, we can simply make it by watching the infant drink. If pyloric stenosis is present, the sphincter around feels very round and firm. It actually is considered what's called a palpable olive shaped mass in the right abdomen. So, if you look at these pictures, especially the one that has the normal anatomy versus pyloric stenosis, where that enlarged pylorus is, you can actually feel that, and it's a palpable olive shaped mass in the right abdomen. And it will become more prominent, especially when the infant has projectile vomiting. As the infant drinks, we can see visible gastric peristaltic waves that move from the left to the right across the abdomen. As part of our diagnostics, they can do an ultrasound and they'll see a hypertrophied sphincter as well. They can do a Chem7 or some sort of metabolic panel, whatever you want to call it. BMP, CMP, Chem7. Really, we're just looking at their fluid and electrolyte status. So we're looking for metabolic alterations. And we would also want to look at their BUN because that can indicate dehydration. Therapeutic management for pyloric stenosis. The only way we can fix this is actually doing surgery. And the surgical repair is called a pylomerotomy. And that's where they will take the muscle of the pylorus and split it down to the mucosa. And what that does is it actually allows for a larger lumen so that fluid and food can pass through from the stomach to the intestines. When you think about preoperative, what do we need to do? A lot of the same typical things we would do preoperatively, but one of the big ones that for pyloric stenosis that we need to do is really IV rehydration, because this child often comes in with some level of dehydration and electrolyte imbalance. So really the IV rehydration is to help correct that. So correct any fluid and electrolyte imbalance. Especially they have a need for additional potassium, but as a rule, you can't put potassium in their fluids until we've verified what have we talked about before? They have to have renal function, right? How do we know they have renal function? Just simply having urine output, so having a wet diaper. And depending on their level of dehydration and electrolytes, it could take up to 24 hours or more to actually restore their fluid imbalance if it is severe. They cannot go to surgery until fluid and electrolytes are back in balance. They'll also need to be NPO, no matter how long we're trying to get that balance back in place, whether it be hours or over 24 hours. They do need to be NPO. We would also want to record frequency of urine output, their specific gravity of urine. We would want to know the number of stools that are passed. That can be helpful in assessing dehydration and starvation levels. Post-operatively, they're going to still have an IV in place, and we would want to assess that and monitor that and continue with IV fluids. And then they will be on a feeding regimen, and that can differ from surgeon to surgeon. But most times it usually involves frequent feedings that are small amounts, gradually increased over time as that feeding is tolerated. So approximately 4 to 6 hours post-op, they are started on a small amount of an oral rehydration solution by bottle. So that could be Pedialyte. I've seen them do glucose water, just something to see if they will tolerate it. As long as there's no vomiting, they'll actually move them to, they'll increase the volume and they'll move them typically to a half strength formula or again straight to breastfeeding because breast milk is considered clears. So usually half strength formula or breastfeeding is begun. And then by 24 to 48 hours, the infant's usually taking full formula diet or again can be fed fully by breastfeeding. The important thing is teaching a parent to burp well after feedings and even in between feedings once they get to those larger volumes. We would want to lay them on their right side after a feeding. That can actually help decrease the chance of aspiration if they would vomit, and it can also help with the flow of fluid through that pyloric valve. It's just aided by gravity. We would want to monitor daily weights, certainly do incision care just like any other surgical incision. So think about pain management, assessing that. Dressing site, we don't typically change that dressing. Oftentimes it's just a little laparoscopic incision and they'll have steri strips or maybe a little gauze there. We don't change that unless absolutely necessary. Thinking about eyes and nose would be important as well. Again, making sure we educate parents about the feeding regimen, pain management, and care of that incision when they go home. So those would all be things for teaching that we would want to do. Again, you can look at some additional the nursing diagnosis and related interventions in your book on hypertrophic pyloric stenosis. All right, now we're moving into our intestinal disorders. And the first one we're going to talk about is intussusception. And intussusception is basically there's invagination of one portion of the intestine into itself. So in both these pictures, you can see what that may look like. They're both happen to be different areas or different invagination, but it can give you an idea of what that telescoping or invagination looks like. Generally, it's at the juncture of the distal ileum and the proximal colon. That's the most common area, but it can occur in other parts of the intestine itself. It most frequently occurs in the second half of the first year, so 90% of cases occur by age 2, and 75% of those cases are idiopathic reasons. So there's no real clear cause. There's kind of this happens with no warning. We don't know why it happens. So most of them are idiopathic. Assessment for intussusception. The child typically will have sudden acute abdominal pain. They'll typically draw their legs up. They have these crying episodes that repeat every 15 to 20 minutes, and they may even vomit, which will contain bile. After that peristaltic wave that caused that discomfort passes, then they will appear like they're symptom-free and maybe play happily or at least be a little more calm and not crying and agitated, right? But what's going to happen is that's going to repeat itself. So about 15 minutes later, the same phenomenon increases. The intensity of the abdominal pain or the intense abdominal pain strikes. And again, it just keeps reoccurring. One of the classic signs that we see is called red currant jelly-like stool. So the stool is a red currant jelly, and that's a classic sign, and that's due to the blood and mucus that's in the stool. And if the abdomen tends to become distended, and that's due to the bowel above the intussusception actually distends. So think about like if there's that invagination, nothing can move through that portion. So that part of the intestine above where the intussusception has occurred will actually distend. They can also have a palpable sausage-shaped mass in the upper right quadrant. So the second picture on this slide, where all the little arrows are pointing to the stomach, you can kind of see the outline of that palpable sausage-shaped mass. So think of like rope sausage. That's kind of what it would feel like if we palpated the abdomen. Again, tends to be in the upper right quadrant, just depends on where that intussusception has occurred, but that's the bowel that has or the intestine itself that has telescoped or invaginated on itself. That's what you're feeling, is that palpable sausage-shaped mass. If necrosis would occur in that invaginated bowel, what we're going to see symptom-wise is increased temperature, increased white blood cell count, a rapid pulse. They're going to have peritoneal irritation, which means the child is more than likely, their abdomen is going to be really tender, and they may guard their abdomen and tighten those muscles. They don't want you touching it because of the amount of pain. Diagnosis for intussusception. It's usually suggested by history just based on their clinical manifestations that they're presenting with, but we can confirm it by doing an abdominal x-ray or an ultrasound. Typically they might start with an x-ray, but they're oftentimes going to do an ultrasound as well. Therapeutic management. This is considered a surgical emergency, and that is typically the only way that we can fix this problem. It very rarely resolves on its own. But surgical reduction of it, what they're going to do is either by, even though they call it surgery, it's not your typical surgery you think of. They're actually going to instill either like a water-soluble solution, a barium enema, or an air or enema is what they'll do. So oftentimes they're taken to interventional radiology, and they'll do one of these solutions or enemas. The most common I saw when I worked at Cincinnati Children's Hospital and at Riley was an air enema. is what they would actually do. So what they will do is what that does is it creates pressure above, especially like in this example with the barium. What that does when they do a barium enema, it will actually create pressure above that intussusception that has occurred. And the pressure of that, the idea is that it will actually pop that bowel back out to where it's supposed to be and resolve the intussusception that way. Afterwards, they would need to be observed for 24 hours because that's the most likely time that this can reoccur. So we would just want to observe for reoccurrence within 24 hours. And in some cases, if the intussusception is not resolved by the barium enema, the air enema, or the water-soluble solution, then in some cases they do have to take them to surgery and manually reduce them if those non-surgical techniques failed. In most cases, I would say probably 95% of the time, those non-surgical approaches where they went to interventional radiology resolved it. Your nursing care, if it's a non-surgical reduction, so meaning like the air enema, the barium enema, or water-soluble solution, they do need to be NPO for, so for your blank, NPO. We would want to prepare them just like any other time for hospitalization, those diagnostic procedures, what's going to happen. They're going to need IV fluids since they're NPO, and pain management as well, leading up to the reduction of this. So prior to the reduction, they have a lot of pain. We would want to manage that. Once we reduce that intussusception, they don't really have any more pain. They feel much better. We've resolved that issue. If we would have to do surgical reduction, of course, they need to be NPO, IV fluids, again, pain management. You also need to be thinking about, again, now you're going to have a surgical incision and all the things that go with the surgical incision care. They could potentially have an NG to low intermittent suction until bowel function returns. And then once bowel function has returned, we would advance their oral feedings slowly. Let's say you're in the ER working and a kid comes in, ends up getting diagnosed with intussusception, and they're supposed to go to interventional radiology to have this reduced. While they're waiting to go to interventional radiology, they end up passing a normal brown stool. If that would happen, then that is indication that the intussusception has actually reduced on its own. And that would need to be reported to the practitioner because that's going to alter what kind of diagnostics and therapeutic care plan we would have moving forward. So if they would pass a normal looking brown stool, then we would want to let the physician or practitioner know, and then they will proceed by doing some more diagnostic tests or changing our therapeutic care plan. The next disorder we talk about is appendicitis, which you should be somewhat familiar with as well from med-surg. But appendicitis is the most common cause of abdominal surgery in children, especially school age and adolescents. It can occur in other age groups, but those are the most common age groups that it occurs in. And it's just inflammation of the appendix caused by an obstruction of the opening. For most instances, it's the fecal material that enters the appendix, hardens, and actually obstructs the appendiceal lumen. That inflammation and edema develop, which leads to compression of the blood vessels and the cellular malnutrition, which can lead to necrosis, and then you get the result of pain. If it's not discovered early, that necrotic area will rupture and fecal material spills into the abdomen, which is what leads to peritonitis, which can be potentially fatal. So again, if that appendix would rupture, that's called a ruptured appendix and can lead to peritonitis. Assessment-wise for appendicitis, pain is actually a late symptom. So diagnosis can be made on a cluster or based on a cluster of symptoms that we typically see. And we can see some anorexia, pain or tenderness in the right lower quadrant that is referred to as McBurney's point, which is the most intense site. So their pain in the beginning will actually be diffuse at first, and then it will localize again to that right lower quadrant. They might have some nausea and vomiting, typically an increased temperature, and they have increased leukocytosis. For diagnostic evaluation, again, based on clinical manifestations, and we can look at their CBC, and they'll typically have elevated white blood cell count greater than 10,000, low for the extent of the infection that may be present. We can also look at ketones levels in their urine. So ketone level in their urine is often increased, and that's just due to the symptom of starvation because of poor intestinal absorption. And most oftentimes we're going to do an ultrasound or CT. Many times they'll start with an ultrasound. Usually it's not exclusive enough in order to diagnose appendicitis. So if they can't give a definitive diagnosis from an ultrasound, then they'll go and do a CT scan, and that will reveal a swollen appendix. They often may also do actually a chest x-ray, and that's because with that right lower quadrant pain, it may be a manifestation of right lower lobe pneumonia. So again, for children, they often complain, even with pneumonia, they'll complain about abdominal pain if it's in the lower lobes. Treatment for appendicitis is actually doing an appendectomy, which is surgical removal of the appendix by laparoscopy, ideally before it ruptures. We'll talk more about ruptured appendix next. We want to avoid the use of cathartics or any heat to relieve that pain while we're waiting for surgery, because that can actually lead to an increased possibility of rupture. We also want to avoid compression of the abdomen during prep of the abdomen for the OR, because again, that could lead to rupture of the appendix. Use of lukewarm or water would be better rather than hot water, because again, heat can increase that possibility of rupture. So no heat packs or anything like that to relieve pain, because it can actually increase the edema and leading to the possibility of rupture. So ideally, we're going to get this appendix out before it perforates. So before perforation, we would want to do rehydration. So they're going to need an IV and IV fluids. Oftentimes they'll do antibiotics and then surgical removal of the appendix, known as an appendectomy. Again, it's laparoscopic surgery is the most common way that they will remove it. And in our postoperative care, as long as, again, there wasn't any perforation, think of just normal postoperative care, pain management, hydration, fluid and electrolyte management, incision care, get them moving afterwards are the big things. Definitely go review the box about interprofessional care map for a child with appendicitis, and you might want to review the nursing diagnosis for appendicitis as well. With ruptured appendicitis, if the child's appendix ruptures while they're being seen in the ER or waiting for surgery, or even before maybe they sought medical care, it increases or can lead to the potential for peritonitis. That really increases when there's ruptured appendicitis. The child will appear severely ill. Their white blood cell count is typically more than 20,000. It would be important to position the child in a semi-Fowler's position if possible. That's just to help keep that infected drainage from the cecum drain toward the pelvis rather than towards the lungs. They're going to need an IV for hydration, and they'll get antibiotics prior to surgery, so preoperatively or as soon as we've confirmed a ruptured appendix. And then during surgery, sometimes they can place drains that can be done either at the time of surgery or oftentimes after surgery. And that's just to help allow that infectious material to drain from the abdomen or continue to drain. In some cases, I've never actually seen this done in all the times I've taken care of appendicitis in the various hospitals I've worked in, but in some cases they may do warm soaks to the incision line 3 to 4 times daily. Typically, even when I've seen kids who are ruptured, it's most oftentimes, well, a lot of times it's still done laparoscopically, because when they've gone in, they didn't know they were ruptured. And while they were waiting for surgery, they happened to have ruptured before surgery took place. But regardless, depends just what the physician orders postoperatively for incision and if there's a drain, what that care might look like. We would still want to examine the wound carefully during any dressing changes if they're ordered. We're assessing for signs and symptoms of peritonitis. So those symptoms might be, or what we might see, is a board-like or rigid abdomen, shallow respirations, and increased temperature. IV fluids and antibiotic therapy will continue until we have full bowel function restored. And our postoperative course is generally just a little bit slower compared to um, appendicitis that is non-perforated. Complications that we can see is local abscess and intestinal adhesions. Our next intestinal disorder we're going to talk about is celiac disease. Celiac disease is an immune-mediated abnormal response to gluten in a susceptible individual. So we tend to find gluten in the protein in wheat and related proteins in rye, barley, and possibly oats. So what ends up happening pathophysiology-wise is that small villi lining in the intestines is damaged by the body's immune system. So it prevents absorption of foods and especially fat. So that'll make sense when we talk about their clinical manifestations next. The assessment for celiac disease. Usually they will develop the symptoms will develop between 6 and 18 months of age, and that's after that introduction of gluten into the diet. So again, thinking about as early as 6 months when we introduce solid foods. And they may not react right away, but again, it depends on when we introduce the foods that have gluten in it as to how quickly we will see symptoms. But other clinical manifestations, they can develop that steatorrhea, which is that bulky, foul-smelling, fatty stools. If they can't absorb, and especially can't absorb fat, again, we're going to see those loose, the foul-smelling and fatty stools. They often will have failure to thrive or poor growth. So again, looking at those growth charts would be important. That would help us tell if they're gaining weight or not. They can get into malnutrition if they're not absorbing enough nutrients and vitamins and minerals. They're going to have a distended abdomen, and that's usually secondary to those vitamin deficiencies. So they tend to have that distended abdomen that we see, and their extremities also tend to be a lot smaller. There's not a lot of muscle there. I tend to kind of think of them as when you see those kids on commercials for in like poorer nations and countries where they've got the really distended abdomen but very thin extremities. A lot of that is because of the malnutrition and those vitamin deficiencies. They can also have anemia present as well. Diagnosis of celiac disease, we look at history, we look at clinical symptoms, we can do a serum analysis of antibodies against gluten. We can also do a biopsy of the intestinal mucosa, and that will often demonstrate changes in the intestinal villi. We can do a stool analysis and test for fat content. And in some cases, what they'll actually do is just simply test the child's response to gluten by placing them on a gluten-free diet. In most instances, the child will gain weight, their steatorrhea improves, their irritability will fade, and that's because, again, we've taken gluten out of their diet and it's not causing all the damage to that small villi, or that small villi are actually, the damage is done, but the small villi have a chance to kind of heal itself or not have as much damage, so then we get better absorption as time goes on. So a lot of times we'll see improvement when they're placed on that gluten-free diet. Our therapeutic management for celiac disease, again, if we trialed them on that gluten-free diet and they improved, then we're going to continue on a gluten-free diet for life. And then, of course, we're going to want to correct any vitamin and mineral deficiencies as necessary. Along with continuing on that gluten-free diet, they need a lot of nutritional counseling. So a lot of our care focuses on nutritional counseling so they can recognize foods that contain gluten. So again, our big offenders are wheat, rye, oats, and barley products. However, gluten can be found in parts of wheat flour, gravy, soups, sauces. Packaged and frozen foods often have gluten in them as well. So really teaching them to read labels and know what kind of things are hidden. It doesn't come out, saying gluten or wheat, rye, oats, or barley. We look for some of those other hidden gluten products. When it comes to diet, corn and rice become the substitute grains that they can have. So corn and rice are substitute grains. And we want to provide strategies for the child to be able to adhere to these dietary management. So initially the bowel is inflamed because of the pathologic process. So high fiber foods like nuts, raisins, raw vegetables, and raw fruits with skins are actually avoided until that inflammation has subsided. And again, with our teaching, they need a considerable amount of time is involved in explaining to the child and family about disease process, specific role of gluten in aggravating the condition, and the foods that must be restricted. The nurse needs to advise parents to read labels carefully, read all those ingredients to avoid any hidden sources of gluten. And many gluten containing products are easily eliminated from the infant or young child's diet, but monitoring the diet of a school age child and adolescent is a little more difficult because they're getting school lunches or they're eating out. Think about birthday parties. We don't always know where those products or food came from and what ingredients are in them. So sometimes we have to be a little more careful. It's easy for them to get into accidentally, but get into food that has gluten, and then we tend to have some symptoms. Right, now we're going to move into disorders of the lower bowel. And the first disorder we're going to talk about is constipation. So there are different types of constipation. You can have functional constipation or psychological constipation. So functional constipation is constipation without an underlying medical disease, where psychological constipation can actually begin because of emotional reasons or become a physical ailment. So, therapy often involves, for that type, counseling to correct whatever the initial problem is and treatment of the physical symptoms. And constipation is a common problem that we see in childhood, often starting as early as the first year of life. So, clinical manifestations. Generally, it's defined as either 2 or less bowel movements per week that causes distress to the child. The stools are often large, hard, and painful to pass, so the child often represses the urge to defecate to avoid the pain, which leads to what we call stool holding. Because of that, can actually create more problems. They can have anal fissures develop. That rectum, because of holding that stool and avoiding the defecation, the rectum gradually becomes distended and it adjusts to that ever present bulk of stool, which then leads to the urge to defecate becoming less frequent. So when the child does pass stool, it's much larger and firmer and it actually causes more pain. They get into a vicious cycle, and that child or that vicious cycle will continue until the child is severely constipated. They may even have what's called endocapresis, which is involuntary release of the stool, and they may have abdominal pain and decreased appetite. Assessment wise, it'd be important to assess a history of bowel movement pattern. History of bowel movement pattern. Examine the circumstances that have led to the constipation. Is it a diet that's low in fiber? Is there little privacy in the bathroom or being able to go to the bathroom? Is there family stress present? Important to know the age of onset of constipation. Are they toilet trained or not? Do they exhibit stool withholding behaviors? And we look at newborns who failed to pass the meconium, that first bowel movement, within the first 48 hours of life, because that's important to differentiate between constipation and Hirschsprung's disease. So our therapeutic management is really aimed at softening the stool so it will pass painlessly. Things we can do bowel cleansing to remove that retained stool with a weight-based appropriate dose of polyethylene glycol, or Miralax is the brand name. That's usually recommended before beginning any sort of daily treatment. Again, to clean out that retained stool. After that, then we can move to a stool softener like polyethylene glycol on a prescribed daily basis. Oftentimes when I've seen kids come in clinically with constipation, what they'll do is they'll actually just give them dose after dose after dose. I mean, literally almost an hourly dose of Miralax to get them cleaned out. And then they'll look at, once they get them cleaned out and the constipation is resolved, then they'll look at other long-term management. And that may be continuing to do daily Miralax. But we also look at diet as well. Enemas are really avoided if at all possible. That can be a little traumatic for the child. It doesn't always clean them out. So, kind of the newer method is to just give them doses of Miralax on a pretty frequent basis. And then afterwards, we want to look at, when we talk about their diet, we want to look at normal fiber intake is actually recommended. It used to be we'd say, if you're constipated, eat a high fiber diet, right? There's actually no evidence to support that a high fiber diet improves stool frequency. So they really just need a normal fiber intake. So normal fiber intake is recommended. We want children to be encouraged to sit on the toilet after meals in an attempt to defecate. Really, that's trying to set up a pattern of regular bowel movements so that we don't get in like the stool holding behaviors and things like that. For young children, they respond really well to positive reinforcement. So one idea is a parent can use a sticker chart or some other small reward as a motivation. So maybe it just starts out as, hey, you go, once on the potty, you get a small reward. We do this even in the beginning with toilet training, right? With potty training. Oftentimes we use a little reward system, like you can have a jelly bean or an M&M. Well, once they kind of get the hang of it, or we get on a more regular basis of doing that, same idea here. Then we move to, let's see if you can get 5 stickers for the week, or whatever set amount. And then if they do, then they either get a small reward or they get something special, either a toy or a little treat or something to accomplish that. So that can be really helpful. Again, positive reinforcement. Our next disorder we're going to talk about is Hirschsprung's disease, also called congenital aganglionic megacolon. Its incidence is 1 in about 5,000 live births. There is an absence of the ganglionic innervation to the muscle of the section of the bowel. So it's usually the lower portion of the sigmoid colon just above the anus that is lacking the ganglionic cells. So an absence of those nerve cells means there's no peristaltic waves in that section to be able to move fecal material through the segment of the bowel. So what ends up happening is they have chronic constipation, and if they would have any stool pass through, it tends to be a ribbon-like stool. So that's kind of a characteristic finding, especially for older children, a ribbon-like stool. Portions of the bowel proximal to the obstruction actually dilates, which then leads to abdominal distension. So in the picture of this slide, what you can actually see is a comparison of what normal sigmoid colon and rectum should look like versus a child who has Hirschsprung's. In the child who has Hirschsprung's, you can see that lower portion, again, close to the anus or the rectum. It's very skinny, and that's because it's got, again, the absence of the ganglionic cells. And how much of that portion is absent of the ganglionic cells varies from child to child. It's case to case. But prior to where the absence of those ganglionic cells is, you can see that we have a swollen colon, or distal, or not the distal colon, but the colon itself is swollen, which leads to your abdominal distension because fecal matter has a hard time passing through there because there's no peristaltic waves because of the absence of those nerve cells. So again, it ends up just creating distension of that colon prior to where that portion of the absence of the ganglionic cells are. So again, on the picture that's underneath assessment, you can kind of see a better portion where it's at least a little bit more labeled, where there's the rectum, and right prior to the rectum is the aganglionic portion. Again, that's lacking those ganglion cells or those nerve cells in order to have peristalsis through there. And then up before that is your distended sigmoid colon, and because stool will kind of collect there, it creates kind of an obstruction, and what will then happen is it just kind of backs things up, creates abdominal distension. But other assessment things that you're going to see in the newborn, if we would find this in the newborn, typically the newborn has a failure to pass that meconium within the 24 to 36 hours after birth. Yes, I know under constipation, I just said 48 hours. Ideally, we want to see that meconium passed within the first 24, 36 hours. So, again, by 48 hours, we should definitely be thinking there's a problem. But typically, for the newborn with Hirschsprung's disease, that's the failure to pass the meconium within 24 to 36 hours after birth. Then we want to be thinking, not necessarily Hirschsprung's, but be thinking that there is something going on. We'd have to do more diagnosis. We're not just going to base it on that. If it's not diagnosed in the newborn period and it's a little bit later, so for some infants and children, it may not be apparent until about 6 to 12 months of age. And they're going to appear thin and undernourished. So think about those growth charts. Those would certainly be an indicator, right, that they're not growing like they should. They will have abdominal distension, and they have a history of not having bowel movements more than once a week. And those bowel movements, it's really important to ask what they look like. So if they're not occurring more than once a week, they tend to have a ribbon-like or watery stools. Ribbon-like or watery stools. Diagnosis of Hirschsprung's disease, it can be suggested by doing a rectal exam. And what we'll find is the rectum is actually empty. There's no fecal matter there because it cannot pass into the rectum through that obstructed portion where there's no ganglion cells. We can also do a barium enema or an ultrasound with contrast, like in the picture under the diagnosis. That contrast will actually outline the narrow nerveless portion and the large proximal distended portion of the bowel. So we can see that in this barium enema with contrast. We can see that outline in that distended portion of the bowel. Our definitive diagnosis, we're going to do that by doing a rectal biopsy. And when we do that, we're going to see an absence of those ganglion cells, an absence of the ganglion cells. They can also do the anorectal manometry, and that will measure the pressure exerted against it. Our therapeutic management for Hirschsprung's disease is to do surgical removal of the aganglionic portion of the bowel to relieve the obstruction and restore normal bowel motility and function. So we're going to do surgical removal. It's actually done in 2 stages. First, they'll do what's called a temporary ostomy, where what that does by creating the temporary ostomy, it actually relieves the obstruction and allows the distended bowel to return to normal size until we can do corrective surgery. When we do corrective surgery, they'll actually create that proximal to the aganglionic segment. The second stage to the surgery or to the treatment is to do what's called a pull-through procedure, and that's typically done at 12 to 18 months of age. Again, there's quite a bit of time that goes between the temporary ostomy and then the second stage of the pull-through. And the pull-through is just pulling the end of the normal bowel through the muscular sleeve of the rectum. So that ganglionic portion has now been removed. Bowel has been returned to normal size. And they'll close the ostomy. So they'll reanastomose or pull the, I shouldn't say reanastomose, they'll pull that normal bowel through the muscular sleeve of the rectum. And then the ostomy is closed at the time of that pull through, and then they should have a normal functioning bowel after surgery is complete. Some nursing considerations to think about: preoperative care, just like any other surgery. There's all kinds of things we need to prepare the family, explain what's going to happen, prepare them for that temporary ostomy. We want to talk to them about nutrition. We want them on a low fiber diet at this time, a low fiber diet preoperatively. Again, because we don't want, since they already have problems with preoperatively with having that aganglionic portion, we want bowel to be a little bit easier to move through since it has a hard time. We often use stool softeners. They're going to need vitamin supplements as well. They may even need daily enemas just until the condition improves, again, to help promote that bowel movement. So we're not getting into the constipation. And then prior to surgery, they'll actually have to do a cleansing of the bowel. So they'll do like a bowel prep procedure or a cleansing whether that be at home or within the hospital. It just depends on the child. Our postoperative care, same as any other surgery. You still have an incision, you've got pain management, all the considerations when they're first waking up, thinking about vital signs and assessments. Um, One thing they may have is an NG to low suction. And if they do, we would keep that until bowel function returns. How are we going to know bowel function returns? Guess what they're going to have? Bowel sounds, right? And then once bowel function returns, then we'll remove that NG and we'll start them on clears and advance their diet age appropriately. They'll be on IV fluids, especially while they're in PO or while we're waiting to advance their diet. And then they may or may not have a indwelling Foley for a little while. And the big thing really postoperatively is family needs stomal care and education. So that's included, again, part of preparing for discharge. They need to make sure they know how to care for that colostomy. So stomal care, skin care, the application of the appliance, how to empty it, anything you can think of when it comes to caring for that colostomy. Again, education about nutrition and, of course, parental support as always. The last disorder we're going to talk about in GI actually comes from chapter 27, that child born with a physical or developmental challenge. And we're going to be talking about oral facial clefts, or more commonly known as cleft lip and cleft palate. So the maxillary and median nasal processes normally fuse between weeks 5 and 8 of intrauterine life, so pretty early on. Think about most women are just finding out that they're pregnant shortly after that time or around that time. The overall rates of incidence for cleft lip and or palate in the average or in the US averages to about 1 in 600 newborns. And cleft lip is actually just fusion fails to occur in varying degrees. So it can range from a small notch in the upper lip to total separation of the lip and facial structures up into the floor of the nose. And I have some slides that will show different variations. They can have a deviation that may be unilateral or bilateral. So we can have a unilateral cleft lip or a bilateral cleft lip. It is the most common oral facial cleft that occurs, and it's more prevalent in boys than girls. It does appear to be caused by transmission of multiple genes aided by tetragenic factors that are present during weeks 5 through 8 of intrauterine life. So again, you can see that list in your notes. I'm not going to go through those. Parents should be referred to genetic counseling to help ensure that they do understand that they have a small increased chance of having another child with a cleft lip or palate, and any future children are at greater risk than usual for this problem. With a cleft palate, it's an opening of the palate. The palatal process does not close as usual at approximately 9 to 12 weeks of intrauterine life. So that can involve the anterior hard palate, the posterior soft palate, or both. And it can occur as a separate anomaly or in conjunction with a cleft lip. Again, result of polygenetic inheritance or environmental influences. So this slide is just showing the stages of the palatine development. So obviously some of these are during intrauterine life and how that palate typically develops or what it should be doing. But when those processes don't develop properly or close, that's when we are left with a cleft palate. These are just some variations of cleft lips and palates. Like you can see in picture A, this child just has a cleft lip, not that severe, just a small little notch in that upper lip, but the palate itself is fine. Where picture B, it's actually a cleft lip and palate. That cleft lip actually extends up into the floor of the nose, and then we can see a variation with an open palate as well. In picture C, this one is a bilateral cleft lip, so it's 2 notches in that upper lip, as well as we can see an opening with the palate. And then picture D is the child who does not have cleft lip at all, but happens to have a cleft palate. So again, just some different variations that occur. And these are just actual pictures of various cleft lips and palates. Again, every case is different. as to the severity and the degree, but again, you can see some differences with cleft lips or cleft palates. Assessment-wise of cleft lip and cleft palate, for a cleft lip, it can be detected on ultrasound or certainly readily at birth by visualization. Cleft palate as well can be detected at birth by visualizing the palate. You can't get a newborn and just say, hey, open up, let me see in there. They can't do that. So the best time you want to do it is catch them when they're certainly maybe crying or upset, and make sure you have good light to be able to visualize. The other important thing to do is typically what happens is the nurse will actually assess with a gloved finger and insert that gloved finger and feel around the roof of the mouth to see if there is a cleft palate present or not. All right, therapeutic management for starting out, we're going to start with cleft lip repair. If it's discovered in utero, they can do fetal surgery to repair that defect, although that is not commonly done. Most times it is done after birth. So if it's discovered at birth, surgical repair will be scheduled for after birth, somewhere between 2 and 12 weeks of age. The deviation of the lip interferes with sucking, so early repair is necessary. That early repair helps the infant experience the pleasure of sucking as soon as possible. And it's equally important from a psychological standpoint, as a parent may need caring support to be able to bond with that infant who has a face deformity. As the child grows, the facial contours change and a revision may be needed when the child is 4 to 6 years of age from that original repair. And sometimes they need nasal rhinoplasty to help straighten a deviated nasal septum. This slide just shows what the end result will look like. In the previous slide, kind of the before and after of the surgical repair of the cleft lip. I do have some actual comparisons of before and after towards the end of this, or at the end of all of this, that you can see. For cleft palate repair, the optimal time for repair is controversial, but we do want early repair because that can help increase speech development. But it may be a result in it may result in a secondary stage of repair as the child's palate arch expands with growth. So we really optimize and want to optimize speech development, so we tend to lean towards early repair of that palate. Surgery, again, may be recommended as a 2-stage palate repair. And the soft palate is typically repaired anywhere between 3 and 6 months of age, and the hard palate can be repaired at anywhere between 6 and 18 months of age. This repair results in less need for future surgery and better facial results, so meaning more facial or better facial asymmetry, not asymmetry, symmetry. Let me get that right. As well as the palate repair narrows that upper dental arch, so it leads to less space for the upper jaw eruption of the teeth, creating poor teeth alignment. So need for follow-up treatment is important. So as that child grows, extractions or realignment of teeth can be done as indicated. They also need follow-up to detect any hearing or speech difficulty, because the angle of the eustachian tube may actually be changed because of surgery. So they can develop more ear infections than usual, which can lead to hearing impairment. And if the hearing is impaired, that can have an effect on our speech development. So referral to speech therapy early in infancy should always occur to ensure successful speech development. When it comes to the nursing care and teaching of a parent who has a child with cleft lip and or palate, there's lots of different things we need to talk about, and not all of it is necessarily education. Some of it is also geared at kind of psychological. So being able to help the parent deal with their reaction, that parental reaction is really important. Even if they knew that their child was going to have a orofacial cleft from ultrasound, it's still seeing it in person is kind of the acceptance and the reality of it that it's true. Because who doesn't hope that maybe that was a misreading or misunderstanding on an ultrasound? So, seeing it for the first time can really bring a lot of different reactions for people. It's really important to help the parent work through those reactions and their um, expressions of grief and their fears. Um, what's really important is you need to address the infant's physical needs and the parent's emotional needs. The infant's physical needs come before the emotional needs of the parent. But it is important to address both of those, and there's risk for failure of maternal attachment, and I actually wouldn't limit it just to maternal attachment. That could be paternal attachment as well. But again, infants' physical needs and care come before the emotional needs of the parent. Um, Again, still encourage the parent to express their grief or their fears that their child does have a deformity or a defect. But it's really important also to emphasize the positive aspect of the infant's physical appearance. We're lucky in our culture and our society, we really put an emphasis on getting these defects fixed early on. Um, Again, part of that is because we do put such emphasis on looks. However, on the cosmetology, not cosmetology, but the looks of things, that we really do a good job of correcting these defects and having a symmetrical appearance. So again, in some of the slides later here in just a couple more slides, you'll see some really nice before and after. And again, it just depends on the severity of that defect. But one thing that needs to be taught is how to feed a child who has a cleft lip and or palate. Because it can be difficult and the parents need to be taught how to feed their infant. Um, they often need some special equipment, just some special bottles like what's pictured here, because they have a reduced ability to suck. So that would really affect especially the mom who planned on breastfeeding. The child isn't going to be able to latch on properly and allow that letdown of milk because they can't have, or again, they have that reduced ability to suck. So some techniques and interventions. They need to be in a more upright position with their head supported or cradled in the parent's arm when they are feeding. And standard nipples won't work. They're inappropriate for the child with a cleft lip or palate. They really need special feeding equipment like what we call a Haberman feeder or a Mead Johnson feeder, which is picture A and B. And then not quite as common in picture C is what's called a pigeon bottle, but the idea is they're all going to do the same thing. When they are getting these, they do need frequent burping done as well because they can swallow a lot of air with these. With Haberman feeder is probably the most common that I have seen used, the Mead Johnson being second. But the idea is that these that has a longer nipple on it, as well as a very flexible chamber that allows control of that feeding for the infant. So it would be important to educate the family how to use those. Again, the breastfeeding issues related to the inadequate suction for milk letdown. So mom is going to have to pump if she wants infant to have breast milk and then use one of these bottles. This slide is just really showing, again, how it would be inappropriate to try and use a standard nipple. Again, like in the first picture, how large that cleft lip is. Wouldn't be surprised if that infant also has a cleft palate. In the second picture, you can really see the use of the Haberman nipple for that infant who at least has probably a cleft lip. So just an example of showing the different feeding device. So talking about the surgical correction of cleft lip and palate, it is a multidisciplinary team approach. It can often involve dental, plastic surgery, ENT. So there's different teams that may be involved depending on each child's case. The goals of surgery is to close the defect and have a symmetrical appearance. For the preoperative, we want to encourage parents to bond with their infant. Again, help parents focus on the infant rather than the infant's defect of the cleft lip and or palate. Help parents to understand any negative feelings such as sadness or anger towards themselves or the infant is normal, and just help them work through those feelings. May even need to refer them to a support group for additional support. And we want to provide instruction to promote feeding, like we just talked about. So, upright position, use of that special feeding equipment, and then we also need to burp more frequently due to the amount of air that is swallowed. Post-op considerations, the infant's going to be NPO for approximately 4 hours, and then we're going to introduce small amounts of liquids. You want to keep the infant and child pain-free to try and decrease any crying and stress on that repair site. We also want to make sure that we are keeping those repair sites clean. For a cleft lip, we want to use sterile saline or water on a sterile swab to clean the incision site. You don't want to scrub across. You just simply take those sterile swabs and kind of roll it down the cleft lip incision because you don't want to disrupt those sutures that are there. And for a cleft palate, we can clean by just doing sips of clear water. That can help rinse that suture line and keep it as clean as possible. We would want to assess for the sites for infection. So looking for your signs and symptoms of infection. We want to assess for any respiratory distress because of that local edema from the repair. They could have some edema that leads to respiratory distress, so assessing for that. May need to suction the mouth to remove any mucus, blood, and unswallowed saliva. However, you have to be very careful when you are doing that not to touch the suture line with a catheter. Most times they actually will not, in my experience, will not allow you to suction at all with anything other than just going right inside the cheek with a flexible catheter. So you would not be using a Yankauer suction, you would just be using a flexible, thin catheter to be able to slide it back in the cheek so that you don't disrupt the incisions, especially if it's a palate. Place the infant on their side to allow mouth secretions to drain forward. And for a cleft lip, you do not allow the infant to turn on their abdomen. Again, you don't want the risk of disrupting those sutures. We would also need to assess their ability to eat. So monitor eyes and nose. For a cleft palate, we need to avoid using any objects for feeding that could harm that cleft repair. So no use of spoons or forks in the mouth. Food really has to be able to just slide right off the mouth or slide right off the utensil into the mouth. And we want to avoid the use of suction or other objects in the mouth, like tongue depressors, thermometers, pacifiers, straws, because especially when there's a cleft palate, and that's just to maintain the integrity of the surgical repaired palate. They also need to have, whether it's cleft lip or cleft palate, they need to have elbow restraints to keep the infant from pulling at the repair site, and those may need to be needed for 4 to 6 weeks after the repair. Some post-op complications that can occur with a cleft lip, there's risk for situational low self-esteem. So again, be important to reinforce the positive attributes of the child. That scar is only a small aspect of who they are. Again, as an infant, they're not really aware of it. But as that child grows, they're well aware, again, of any differences that set them apart from their peers. So even though that scar might be fairly small, it's still noticeable to them. And again, they don't like that being different. It, again, changes their self-image and certainly self-esteem. So definitely try and reinforce those positive attributes. For a cleft palate, they have a risk for ear infections. Again, it'd be important to review signs and symptoms of ear infections with parents so those can be treated or diagnosed and treated appropriately as soon as possible. And we would want to do routine screening for hearing loss. And again, risk for those ear infections because remember I said earlier that with the repair, that often changes the angle of the eustachian tube, which can make them more prone to ear infections. They are also at risk for impaired verbal communication. And that really depends on the age of the repair. If the palate repair is delayed past 2 years of age, then oftentimes they'll give them or create a plastic prosthesis to cover the incomplete palate. That way, the child is able to articulate better for speech, and often they'll require intervention by a speech pathologist prior to school age.